Maybe I should start. Okay, as president of the IUSSP, the International Union for the Scientific Study of Population, I'm thrilled to welcome you to the first of a four-part webinar on the COVID-19 pandemic and sexual and reproductive health in Africa. The following three webinars will take place at the same time over the next 3 days, and I hope everyone who is here will be able to continue to participate in those events. These webinars are part of a new IUSSP webinar series, and to date, most of them have focused on aspects of the COVID-19 pandemic. I'd like to encourage everyone here to keep their eyes on the IUSSP website for upcoming events. IUSSP members will receive invitations to register for IUSSP events, though we do post events for other associations on our calendar. You'd need to take a look at that. And non-members, of course, need to look at the IUSSP website to find out about IUSSP events. Just a real quick aside before we go on, graduate students can be IUSSP members for free for up to 4 consecutive years. This is a great way for them to be aware of these sorts of events, become much more involved in the international demographic community. And I think this is especially important in the time of COVID-19 when many graduate students are finding themselves to be isolated. I want to thank Clifford Odimegwu of Wits University, who organized today's event, and the 3 that follow. He will also be today's moderator. This is the first time that an IUSSP webinar has been proposed by a member rather than being organized top-down by the IUSSP. I'd like to encourage others to also propose webinars, noting that they should be international and ideally interregional in nature, with a diverse set of speakers of top quality and on topics of interest to many IUSSP members. I also want to recognize the sponsors of today's event, in particular the Demography and Population Studies program at the University of Witwatersrand in South Africa, which has been working in collaboration with the National Institute for Humanities and Social Sciences, also in South Africa, and the Population Geography Research Group at the University of Nigeria. Today's event addresses the potential and actual implications of the pandemic for adolescent sexual and reproductive health and rights in Africa. Before I turn the mic over to Clifford, Mary Ellen Zupan of the IUSSP will briefly explain how this webinar will work. Thank you.
Okay. Hi, everybody. Very quickly, I just want to explain to everybody who's not familiar with the ISP webinars how the question and answer will work. Please do not use the chat. Open up the Q&A, which is in the middle of your screen, and push it off to the side. We'd like you to also give thumbs ups to any questions you like. That will move a popular question up to the top. It's often better to like a similar question to your own rather than posing the same question over. For questions that you might like to ask of a specific speaker, we'd also ask you to include their name in your question. And finally, if time permits, the moderator may allow some of you who'd like to speak to orally either ask a question or make a comment. If you would like to do this, we ask you to use the raise your hand feature so we know we're interested. And then if you are called on, please keep comments to less than 1 minute. Okay, after the webinar, please respond to the short post-webinar survey that we'll be sending out that lets you know what you like. And we also ask if you would indicate which country you're based in when you attended, so we know a little bit more about internet connectivity. And finally, as Tom Legrand had mentioned earlier, if you have a topic of interest, send a description and a list of potential speakers to contact@iussp.org. And I hope you enjoy this webinar, and I'm going to turn it now over to the moderator, Clifford Odimegwu. Clifford, it's yours.
Thank you, Mary. Thank you, wonderful participants and panelists in this section. We are going to have the first session for this webinar. We have 4 speakers. One main speaker, Dr. Caroline Kabiru from APHLC Nairobi. She's going to set the tone rolling. And then we are going to have country perspectives on the implication of COVID on adolescent and sexual reproductive health in those countries. So I will now call on Caroline Kabiru to take the lead, taking note of the time allocation. Thank you.
Thank you very much, Clifford, for the introduction and as well for the opportunity to participate in this important and timely discussion. In this short presentation, I'd like to reflect briefly on the implications of the pandemic on adolescent sexual and reproductive health, and then share a few thoughts on research and programmatic needs as they relate to understanding and addressing the impacts of the pandemic and health crisis in general on adolescent sexual and reproductive health. So I thought I'd begin with this slide that just shows that in brief, the data gathered on COVID-19 so far indicates that adolescents aged 10 to 19 are at a relatively lower risk for COVID-19 related morbidity and mortality. In this chart, which is taken from data from South Africa collected in late June 2020, adolescents at that point comprised less than 1% of those who had died from COVID-19. However, the resultant measures to contain the spread of the virus may have significant impacts on other aspects of adolescents' health and well-being, including their sexual and reproductive health and rights. In Kenya, where I live and work, there have been widespread reports about a rapid increase in teenage pregnancy as a result of the pandemic. However, there have been a lot of, as well, public debate about the numbers behind these headlines. So the recentness of the epidemic means that in general, there's limited evidence on these wider impacts. And the strongest evidence, at least from where I'm sitting, may perhaps come from studies looking at the effects of other pandemics or health crises, such as the Ebola epidemic in West Africa several years back. In a quick literature search that I did in preparation for this presentation, I came across quite a number of papers that have reported on the analysis of data to assess the wider impacts of the Ebola epidemic and some of the resultant preventative measures. So I'll start with one paper by Banyera and colleagues, which is one of the papers that has looked at the impacts of the Ebola epidemic on adolescent sexual and reproductive health. In their study, they used data from a randomized control trial that was designed to test the effects of an empowerment and livelihood intervention and was targeting adolescent girls and young women in Sierra Leone. So because the rollout of their intervention coincided with the Ebola epidemic, they were able to look at whether school closures in the country during the Ebola epidemic had persistent effects on adolescent girls and young women. As shown in panel A on the left, aggregate school enrollment rates dropped from 45% at baseline, which was in 2014, that's in the pre-epidemic period, to 38% at endline, which was in 2016, which was in the post-epidemic period. In the panel B, that's on the right, the authors show the different reasons for dropout. And we see that there was a change in those reasons through the epidemic. So at baseline, which is the bars at the very left-hand side of that graph, at baseline among girls aged 12 to 17 who had already dropped out of school, the modal reason for dropout was cost, followed by pregnancy. Post-crisis, which now was in 2016, the modal reason for dropout was pregnancy, with more than a third of girls reporting pregnancy as the reason for dropout. So the authors suggest that school closures might have increased girls' exposure to the risk of pregnancy. In this panel, they present survival functions where the horizontal axis represents the time in months from May 2014, the start of the epidemic, or May 2012, the start of a counterfactual 2-year pre-epidemic period. And so the vertical line, the one on the left with where the arrow is pointing, shows when the school started to reopen. And the second arrow is pointing to a line where Sierra Leone was declared Ebola free. At time 0, each sample includes only girls who are aged 12 to 17 years in the reference year that had never been pregnant. And so what we see is that in the 2 years prior to the epidemic, about 10% of young girls became pregnant. And in the 2-year window of the crisis, prior to the proportion rose to around 15% becoming pregnant. So in short, the research does suggest that the pandemic, the epidemic in this case, and the resultant measures that were taken to prevent the spread of the virus may have had an impact on adolescent sexual and reproductive health. So I'll now shift gears slightly and look at another paper that I thought is also useful in demonstrating the potential effects of the pandemic on adolescent sexual and reproductive health. So in this particular paper that is showing on the screen, Kamara et al. Were using routine service data in a rural district in Guinea. And they were able to show that in the first 3 months of the outbreak, that's the bubble to the left, there was an increase in the use of family planning services. Then that was followed by a significant decline during the peak of the epidemic, with numbers slowly returning to pre-Ebola levels after the epidemic. So we already know that from previous research that adolescents in much of Africa face significant challenges in accessing sexual and reproductive health services. So while these data are not specific to adolescents, we do know that the implications of the pandemic on their behavior is likely to be even more severe. And in a recent set of interviews that we conducted, that was conducted by colleagues at the African Population and Health Research Center, several girls and young women did in fact note that travel restrictions that have been put in place to prevent the spread of COVID-19 have actually affected their access to contraceptive services. So beyond pregnancy and utilization of health services, there is also evidence about the potential effects of the pandemic on other aspects of adolescent sexual and reproductive health. For example, an ongoing study by the Population Council in 5 informal slum settlements in Nairobi suggests that the pandemic has already affected women's and girls' ability to buy sanitary towels, with about 1/3 of the women in their study saying that they had not been able to buy sanitary pads during the closures and restricted movements. Also, although actual data are relatively hard to come by, there have been reports of increased gender and sexual-based violence. There are also concerns about young people's access to comprehensive sexuality education when we're talking about a time when schools across the continent have been closed, though reopening now slowly by slowly. So making sense about the potential impacts and thinking about possible pathways, I think it's useful to reflect upon those pathways. And in a paper on the sexual and reproductive health of adolescents and young people during the COVID-19 pandemic, Lindberg and colleagues, I feel, present a useful framework for thinking about some of those pathways. They were, of course, using data from the United States, but I think it's relevant even here in Africa. So they outline distal, social, and economic changes, such as the measures that are being put in terms of social distancing, sheltering in place, and school shutdowns, having a direct effect on proximal influences, such as proximity to sexual partners. For example, the paper by Banyera and colleagues, they actually did look at whether girls were having more time to spend with potential sexual partners and suggest that that's the pathway to increased teenage pregnancies or adolescent pregnancies. So I do think that this is a useful framework in thinking of assessing the effects of the pandemic on adolescent sexual and reproductive health. However, I do feel that that assessment requires data. And I'd like to then now focus on a few reflections with respect to that very point. I think the pandemic or the crisis has brought to the fore the importance of data systems and platforms that can allow us to better understand the effects of the COVID-19 pandemic and similar crises, as well as to monitor and evaluate programs intended to mitigate the negative effects. In Kenya, for example, fears about the impacts of school closures have been downplayed by some actors who argue that school closures are not likely to have long-term effects. The truth is we don't have enough data to support that either way, though I think the study by Banyera, which I talked about earlier, gives us valuable insights on possible long-term effects of some of the measures. That said, I feel that they were able to assess the possible impacts of the Ebola crisis on adolescent pregnancy because the outbreak occurred as they were implementing their evaluation study. Similarly, in Kenya, some of the data that's coming that's quite rigorous and timely is really being based on longitudinal platforms that were already in existence. However, such platforms, I feel, are few and far between. So I feel that it's useful to think about how we can advocate for investments in platforms, data platforms and longitudinal platforms, other data monitoring systems that will generate the critical evidence or data that needs to guide responses to health crises such as COVID-19. And I also think we need to think about how we add an equity lens to data systems to ensure that they are capturing the most vulnerable adolescent population. Second, the demand for data on COVID-19 has raised some interesting questions about research ethics and how we collect data when face-to-face interaction is limited. When speaking of data collection with adolescents in our context, and here I'm speaking about Africa and at least the part of Africa that I'm living in, is how do we reach adolescents in a time of crisis? Whether it's phone-based interview, do enough of them have access to phones? If yes, we're able to reach them through the phones, how do we get consent and ensure that we're really getting consent from their guardians or parents? How do we ensure that privacy and confidentiality are maintained when we're having to ask very sensitive questions? So I feel that the COVID-19 crisis has brought is making us think a little bit more deeply about research ethics. The other thing I've noticed in my quick review as I prepared for that the presentation is that most of the reports on the effects of the pandemic and other health crises on adolescent sexual and reproductive health or sexual and reproductive health in general focus on its impacts on adolescent girls and young women. However, in line with the recommendations from the International Conference on Population and Development, ICPD, the program of action says we need to ensure that we consider the implications on adolescent boys and girls. So I think that's something else we need to be reflecting on as we move along. How do we ensure that we are capturing the effects of the pandemic and other health crises on the sexual and reproductive health of adolescent boys? Finally, although there's been a significant number of national and international guidelines that have been released that outline the need for sustained provision of sexual and reproductive health services and information, I feel, at least from my experience sitting in Kenya and participating in some of the discussions around the development of guidelines, is that the pace of the guidelines appears to be much slower than the generation of the guidelines. And I think implementation research would be critical to guide the timely translation of those guidelines into programs that can be implemented rapidly and at scale. And in particular, I feel that we need to better understand the role of formal and informal community structures in addressing the effects of the pandemic on adolescent sexual and reproductive health, since many young people are outside of the setting that we typically find them, that is in schools. So I'll end there and allow the others to speak from country's perspective. But before that, I'd like to acknowledge my colleagues, Anthony Ajahi, Kenneth Juma, and Maggie Moka, who gave me very critical insights as I was developing the presentation. And of course, I thank Professor Odimwegu and IUSSP in general for inviting me to be part of these discussions. So thank you.
Thank you, Catherine. The next presenter, country perspectives. We want to hear from Akyode Akorede, Nigerian perspective on the implication of COVID-19 for adolescent and sexual reproductive health. You have 10 minutes.
Thank you, Prof. Good afternoon, everyone. Thank you also, Caroline, for setting the tone for this session. I think you have really set the tone, so this would make my work a lot easier. So I'm going to be focusing on the country perspective and actually on the actual and potential implications of COVID-19 on adolescents. So as a form of outline, I am going to be sharing some country context and then move towards some of the pre-COVID-19 AY/SRH issues in Nigeria. And then we'll move forward to talk about how COVID-19 is in Nigeria and its impact on adolescent sexual and reproductive health. To emphasize the impact it's had so far, I would take a learning from the Ebola crisis from Sierra Leone and then give a couple of conclusions and recommendations. So starting with the country context, Nigeria has an estimated population of about over 208 million. And of course, that makes Nigeria the most populated country in Africa and the 7th most populated country in the world. Mortality is one of the highest, 5.2 per 100,000 live birth. Total fertility rate is still at 5.3. And modern contraceptive use is also one of the lowest, if you consider it across the world, at about 12%. Only about 43% of births is attended by a skilled professional, and under 5 mortality rate is about 132 per 1,000 live births. So 35% of modern contraceptive need is met. So you can see that gives you a rough picture of what Nigeria is at the moment when it comes to issues around population, sexual and reproductive. If you take a dive into adolescents, you'll see that adolescents are about a third of that number, and that puts it about 60 million. And like many of us know, that's more than some of the population countries also in Africa. Adolescent birth rate is about 106 per 1,000 according to the most recent NDHS. Contraceptive use is 2.4%. Unmet need for family planning 19 is about 12%. Among females that are 14 years and above, intimate partner violence is about 30%. And of course,
We lost him. Hi.
Clifford, may I suggest you move on to the next speaker and we'll see if we can get him back in with his PowerPoint and without video before the end, if that's okay.
All right. Dr. Vespa, are you there?
I'm here, Prof.
Can you give us the Zambian perspective? Because of time, you may go straight the brief on issues you present.
Okay.
Yeah.
Okay, thank you. Hello, everyone. My name is Vespa Chisumba from University of Zambia. I'll give a Zambian perspective of the impact of the COVID-19 situation with respect to sexual and reproductive health. Zambia is one of the countries in Southern Africa with an estimated population of 18 million as of 2019. The COVID-19 outbreak was declared on 18th March. Then we only had a few cases, about 2 to 8 cases. Today we are standing at 12,097, that is cumulatively. And if we look at the distribution by sex, about 66% of the cases are male and 34% are female. And by age group, we see that from age group 20 to 29, about 22%, and 30 to 39, 28%. And for the 40 to 40, 44, about, I can't see the figure here, there's something blocking me here. Okay, and then for those 50 years plus, about 18%. So deaths, we're standing at 288 as of today. That is COVID-related deaths. And of these deaths, the Ministry of Health has noted that about 76% of these deaths are brought in dead. And this is an issue of concern as it reflects that people probably are not seeking health care in time for them to receive medication and be able to recover from this epidemic. Active cases, there are about 340. The good thing about this is that in terms of recoveries, the recovery rate has been over 80%, and the mortality rate is less than 1%. The map there shows at the beginning of the epidemic, on 18th March, as you can see there, we only have Lusaka, which is the headquarters of the provincial headquarters of Zambia, also for the province, and you can see that the hotspot, there are only 2 cases then. Today, this is the situation that we have. You can see the red there means the provinces that have the most cases, and then those that are light yellow and darkish yellow also have cases. So in essence, we have cases the whole entire country. And that gives a bit more statistics in a snapshot in terms of cumulative cases and the recoveries, as well as the actual AIDS dates and those that are associated with COVID and the active cases. And that's the distribution that I had talked about earlier on in terms of age groups, and the pie chart there shows the distribution of cases by sex. So in terms of the measures, we need to look at the measures that have been put in place, because these are the ones that have implications on sexual and reproductive health services or rights. So we had the measures that were put in place, a partial lockdown or COVID-19 restrictions. We didn't have a complete lockdown, as has been in other countries, but we did have only two districts that had a complete lockdown at the beginning of the pandemic, but that was only for 5 days. But the rest of the country now only has COVID-19 restrictions. So we have mandatory wearing of face masks in public places, frequent washing of hands, as well as sanitizing, closure of social places like bars and nightclubs. So these up to today, they remain closed. We have the limiting of numbers of people to about 50 in any social gatherings such as church, weddings, or attending funerals. The maximum is 50 or less. Then we also have the closure of schools, and this has been mostly to non-examination grades. Only the examination grades now are open. So also we have to practice social distancing of 1 meter or to 2 meters. And then handshakes in terms of greetings have been replaced with non-touch greetings. So we also have travel restrictions in terms of not having or making unnecessary travels to other parts of the country, only the necessary one. And then people are encouraged to stay at home or to work from home. So these are the measures in place. So in terms of effects on sexual and reproductive health, especially the restrictions in terms of movements, they stay at home. This has meant that people cannot easily move around, though they are still at liberty to move around, but to limit the spread of the epidemic, we are encouraged to stay at home. And those restrictions means that people cannot easily get to get the sexual and reproductive health services, so they'll have to think twice whether they have to really go to a health facility to seek sexual and reproductive health services. Then secondly, we also have, there's fear of getting the infection from the health facilities, because the health facilities, that is where you are finding people who are going to seek medical attention there. And there are chances that if people get to the health facilities, probably they can contract the infection. So there's this fear around in terms of people going to the health facilities. Then there has been an economic impact in terms of people being able to make income for their households, and that has meant reduced income. So meaning that to move around, they are not having enough income to enable them to move to health facilities. And because these restrictions which are in place mean also that some women that have some health conditions, those conditions may actually remain untreated. And this could have future implications in terms of their sexual and reproductive health. So we have also had the situation where there have been reports in the media and from some organizations that there has been a diversion of sexual and reproductive health workers to COVID-19 response, because this is considered to be an emergency. So that means that only a limited number of staff are available to provide sexual and reproductive health services at the facilities. And also that has meant that there is less concentration in terms of providing family planning services. Also, this diversion of financial resources, resources that are needed for the COVID-19. So that means that sexual and reproductive health services are not considered to be essential. So the COVID-19 response is considered to be essential. So therefore, we have a shift of health resources to respond to the COVID-19 response, and thereby affecting the sexual and reproductive health services. Then we have also had situations where health workers have been contracting COVID-19. From the ministry, reports indicate about 300 workers, or over 300 health workers have been infected with COVID. And that means that these workers have taken offline in terms of providing sexual and reproductive health services if they have to. Also the quarantining, and also the limited personal protective equipment. So therefore, somehow there's also a fear in terms of the health workers being in the front line of COVID-19 response, and also them being able to provide sexual and reproductive health services. So we have also seen a situation where there's limited screening of sexual and reproductive health services. This is because the focus now is responding to COVID-19. And because of that, there has been a reduction in terms of the number of pap smear tests, as well as the screening of STIs, and a reduction in the gynecological visits by the women. There has also been a scale down in terms of sexual and reproductive health outreach services. An example which I can give here was the Measur Stops International. They have had outreach services on sexual and reproductive health services, but they have had to scale down, and in terms of also having community mobilization, because you need to put in place measures and ensure that all the health guidelines are adhered to. For example, maintaining the 1 meter social distance, as well as the wearing of face masks if you have to do community mobilization. So they have scaled down on this. So the vulnerable populations have also been impacted, and more especially with respect to access to information, because now the focus has shifted to only looking at COVID, and there isn't much information that is being disseminated with respect to sexual and reproductive health. There has also been an impact in terms of the commodity supply. There has been a disruption in terms of the supply chain system. As we all know that borders were closed, airports were closed, and some factories closed in terms of producing some medicine. So eventually along the line, we have seen that we are having shortages of some of the sexual and reproductive health commodities. And this has been highlighted by some of the non-governmental organizations, such as the Medicines Transparency Agency, which is based on the Copper Belt, which attested that they have observed a shortage of contraceptives at some of the health facilities. So this has meant that there is a threat in terms of the availability as well as the continuity of sexual and reproductive health services. And this has also meant that the women are being exposed in terms of unintended pregnancies because they do not have the contraceptives that they are supposed to use to prevent these unintended pregnancies. And in the long run, this might also impact in terms of the fertility preferences for the women, as they are unable to limit the number of children that they are supposed to have. Just besides the sexual and reproductive health, it's also connected is the gender-based violence. In the media, as well as organizations that deal with sexual and gender-based violence, have also reported an increase in terms of the cases of gender-based violence because of the restrictions. And as more people are encouraged to stay at home and to lessen on movements, so the women get more vulnerable in terms of gender-based violence. And this has also been compounded in terms of a number of factories as well as some workplaces that have been badly affected by the effects of COVID-19, whereby we have seen loss of jobs, and which has led to lack of income. And in the process, the women become the victims because of the economic and social stress. Also connected to that is the closure of non-examination grades, more especially for the secondary school part, where we have teenagers. Now, there have been a number of reports, more especially in the rural areas, where there has been an increase in terms of teenage pregnancies. These are also the effects of COVID-19 in terms of the gender-based violence. So here I'm suggesting what could be some of the interventions which can be looked at. Ensuring that. Hello.
Vespa, you've overshot more than 10 minutes.
Okay. Can I stop by just highlight some points? This is the last slide.
Please do, quickly.
Okay, thank you. Okay. So the point I want to highlight is that there's need to ensure that the supply chain of SRH commodities remains uninterrupted. If this has been interrupted, that measures are put in place, as well as funding. More funding is needed in terms for sexual and reproductive health services, and we need also more health workers should be assigned to ensure that the sexual and reproductive health services are made available to the women. Thank you. I'll end here. I'd like to thank Professor Odumegu as well as IUSSP for according me this opportunity to be part of this webinar. Thank you.
Thank you, Vespa. Hello, we are going to recall Akiode to complete his presentation. Yeah, Akiode, you have less than 10 minutes to do that.
Okay, thank you very much, Prof. Thank you, everyone, and apologies for that connectivity issue. Just to move quickly, Nigeria is the most populated country in Africa, 7th most populated in the world. Maternal mortality is one of the highest, 512 per 100,000 live births. Total fertility rate is at 5.3 per woman, and modern contraceptive use is about 12%. Only about 2 out of every 5 deliveries are attended to by a birth attendant, by skilled health personnel. Met need for modern family planning is about 35%. If we relate these numbers to those of adolescents are about 1/3 of the Nigerian population, putting them at about over 60 million. And as we know, many countries in Africa may not even be up to these figures. Adolescents birth rate is at 106 per 1,000. Modern contraceptive use among adolescents is 2.4%. Just to round up with this context, to say that among women 15 to 49, those that are able to make decisions, who make decisions about their sexual relations and other RH issues, are just about 1/3. Next slide, please. In Nigeria, a typical adolescent is confronted with lots of issues. And as like we know, adolescents are generally a vulnerable population, always confronted with some unique health issues, ranging from unsafe abortion to pregnancy, unplanned pregnancy, and of course, other issues that are related to early marriage. The adolescents in Nigeria have negative health outcomes that could be attributed to the fact that there is poor access to information, poor access to youth-friendly services that could help. Several studies in the country have also shown that if we improve access to information and services, that the health outcomes among adolescents can improve. But the challenge is the poor utilization of these services. And this is attributable to stigma, discrimination, and this happens at all levels, whether at the community level or at the health system level. Next slide. The first COVID was diagnosed in Nigeria on the 28th of February, 2020. And as at Friday, 27th of August, over 53,000 cases have been confirmed, and that has resulted into over 1,000 deaths. To curtail the spread, as at that time, the first lockdown in Nigeria started on the 29th of March, and this lockdown varies in degree across the country depending on the severity of the problem. Next slide. So on this slide, I tried to pull out a couple of some of the implications that COVID-19 brings to a typical Nigerian adolescent. And for example, because of COVID-19, most governments and health systems have deployed service providers to offer COVID-19 related services. Sometimes some sexual and reproductive health services have been closed down within some of the hospitals because either the hospital is trying to prevent transmission, or whether some of the providers have been deployed to do other things that are related to COVID-19, or whether there is need for the space. So everyone, and of course a typical adolescent in Nigeria, is also not, trying not to go to the hospital because they want to avoid being infected. The other implication of all of the lockdown that was introduced is the fact that, implementing partners that are, trying to, that provide services and information to adolescents were also not able to function. And so that means those that were even able to get services are no longer able to, and so on and so forth. Cost of services, of course, cost of transportation, cost of items also skyrocketed around that time. And of course, adolescents are a vulnerable group, and not being able to pay for transportation for instances where some of them have even made those decisions is also something of interest. Chemists, pharmacies that also offer condoms to young people were also prioritizing the stocking of COVID-19 related consumables. And like Caroline and other presenters have talked, the times of lockdown, especially times of crisis and of course lockdown, vulnerability for adolescents for gender-based violence is also very increased. Please, next slide. So the point here is looking at what does all of this mean in terms of their impact on a typical Nigerian adolescent. I decided to take a learning from the past, just like what some of the presenters have shown. And the key point that I like to establish first again is the fact that, in time, one of the leading causes of deaths among adolescent girls, for example, between 15 and 19, is pregnancy, is related to pregnancy and childbirth. And these issues increases in time of crisis. The time of the pandemic is a typical time of crisis. If we take a look at a report from Plan International, that report showed that when schools were closed during the last Ebola crisis, that there was a steep increase in unintended teenage pregnancy. And this, of course, resulted into very significant 75% increase in maternal mortality among adolescents within the 18-month period of the crisis. Some of the recent projections from UNFPA have also shown that if the lockdown continued for about 6 months, that about 47 million women may not be able to access contraceptives. And of course, that may result into 7 million of those women not being, having unintended pregnancies. And because of the vulnerability of adolescents, this is a big and serious issue for adolescents. And of course, this may have inevitable implications for risky deliveries, unsafe abortion, and death. And adolescents are usually at the stage for this. Next slide. So as I try to conclude with this last slide, I think the first point I like to make, like the previous presenters, is the fact that in times of crisis, lockdowns, restrictions, where people are not able to move, there is increased challenges for everyone, and more so for adolescents because of their very vulnerable nature. And of course, these are more serious in settings and like Nigeria. And of course, to also say that countries and governments who have said, oh, we haven't seen this type before, I think I like to say that learning from the epidemic of the Ebola would be a really critical starting point for those governments and those systems. And lastly, to say that putting in place critical resources and systems for times like this can help prevent the serious disruptions that the similar pandemic in future could bring. And this would really bring about some protection for everyone and especially adolescents. Thank you very much.
Thank you, Mr. Kyode. We go to Zimbabwe, Harare. Mr. Papera, can you go straight to your point, to your slides, and then you're finishing at 6 o'clock dot. Please. I'll suggest you go straight to implications and the potentials now.
Thank you so much, Prof. I'm Talent Tapera. I'll take you through the country perspective for Zimbabwe. Basically, just a quick on country context. Zimbabwe is landlocked in southern Africa, and it borders Mozambique, South Africa to the south, Botswana to the west, and Zambia to the northeast, and a population of 13.5 million, with 52% being females. And Zimbabwe is basically as a young population, with 62% being below the age of 25. And the country is also recovering from the effects of Cyclone Idai in the Manicaland province. And also over 5 million Zimbabweans have been noted as being food secure, and 2.2 million of them are in urban areas. And with regards to COVID-19, we have about 5,056 cases, of which 6,406 cases, of which 5,056 are recoveries, with 196 deaths. And these are mainly concentrated in the major capital cities, Harare, and the second largest capital city, Bulawayo, in Matabeleland. And there's been an exponential increase in the rise in cases as from March up to now. But in terms of case fatality, they've been on the decrease. Yeah, with regards to the evolving COVID-19 response in Zimbabwe, first case was confirmed on the 19th of March, and since the government has instituted long-term lockdown measures, and these measures have been the ones that have been had implications on sexual reproductive health, and among them being compulsory wearing of face mask, observing social distancing, regular hand washing, restricted movements, and also virtual meetings in other organizations. And with regards to the comparison in South Africa, as you can see, South Africa has had a lot of cases as compared to Zimbabwe. And as I delve into the impact, I would start with the impact of school closures in Zimbabwe on SRH. And you would find that in Zimbabwe, the major source of comprehensive sexuality education has been schools, and the access to information has been building the urges of girls, and also ensuring that there's access to SRH information and the services as well. But so with regards to the school scholars, there's been non-accessibility of this information, and this may result in the practice of body autonomy, issues of social protection being compromised, and also increase to sexual abuse. And unfortunately, there's a potential of increase in teenage pregnancies, and also poor nutritional status with regards to pregnant and lactating girls. And also the number of home deliveries by unskilled workers is now rife, and also this may cause teen pregnancies, may result to unsafe abortion, and also the factors plunges issues to do with higher maternal and infant mortality and morbidity as well. And there's also been an increase in sexual violence and exploitation in Zimbabwe over this lockdown period. And also due to the issues I have mentioned earlier of lack of food in the households, there's presented an opportunity for probably adolescents to engage in sex work. And also, this further worsens the poverty levels and new STIs, HIV incidences, unwanted pregnancy, stigma, and mental health problems are among problems that are being expected for girls. And the national GBV hotline, the SASA project, has also recorded an increase in the number of phone calls with regard to sexual and gender-based violence among adolescents. An increase, they recorded around 4,000 in July, and this being compared with around less than 1,000 or less in the pre-lockdown period. So there's an average increase of around 70% of the cause being related to sexual violence and exploitation. And there's also been a huge compromise on access to sexual and reproductive health and rights in Zimbabwe due to the COVID-19. And you would find that this includes now the lack of issues to do with sexual reproductive information provision, safe abortion care, issues to do with gender-based violence, infertility, and reproductive care as a result of the complications with regard to the COVID-19. And also, Zimbabwe usually thrives on community health workers, such as we usually called village health workers in the villages, whereby these are very critical in the provision of family planning. And these have been affected disrupted by the supply chain, and their movements have been severely curtailed by the lockdown restrictions. And going into issues of the curfew has been instituted, whereby it's from 6 a.m. to 6 p.m. And issues to do with service providers, such as the mobile or SGBV teams in some districts have reduced operation hours, and they have to return to their bases before 6 p.m. And also there's been closure of health facilities due to this current healthcare crisis, and you'd find them compromising timely access of post-rep treatment. And also the issues of sanitary ware has been severely affected, and particularly there have been an increase in prices of sanitary ware, and this has posed some effects with regards to menstrual hygiene and dignity of adolescent girls at large. And there's also been issues with regards to restricted to movement, and this has severely been a bar against access to sexual and reproductive health in Zimbabwe. And you would find that in some instances, adolescent girls and young women living with HIV may fail to access ARVs, which may reverse the gains with regards to HIV treatment in causing issues such as defaulting, new infections, and related morbidities. And also the issue of reduced public transport availability remains a challenge, particularly in the peri-urban, urban and peri-urban areas, where adolescent survivors of sexual gender-based violence cannot access timely multi-sectoral services. And also there's been the issue of fear of encountering with the police and soldiers once they seek health services. And this is just one quote from Rotendo, who had noted that just for the fear of being beaten up, was afraid to go and buy a medicine. So these are some issues that adolescents are having to take into consideration before accessing services, thereby hindering their access to services. And as for regards to recommendations, first one is that probably the national and the local health authorities should list sexual reproductive and health services as ensuring that there's access to adolescent-friendly services and also reproductive health information. And also there is need to promote innovative approaches such as virtual learning, where age-appropriate sexual reproductive health services may be shared through SMS, various online platforms, TVs, and community radios, for example. And also there's need to invest in PPE for adolescents, and additionally also for community-based cadres to enable them to provide doorstep distribution of services such as contraception, among others. And also there's adolescent girls and young women living with HIV could be at risk of interrupted supplies. And also there's also need to ensure that programs targeting adolescents living with HIV also ensure that they provide issues such as cervical cancer screening, condoms, among others. And also there's really a need to link adolescent girls and young women to packages such as economic strengthening to ensure that food security is achieved, and so that we avoid issues of them having to get into risk jobs such as sex work. So this is the end of my presentation. Thank you so much. Acknowledgements to Professor Odumegu for giving me the chance to be part of this panel, and also staff at the IUSPPP. Thank you so much.
Thank you, Tapera. Right, we have to give attention to the discussants. You have just, if you can do it 10 minutes, we're okay, because there'll be questions. So that we'll use the next 20 minutes to ask questions and address the questions, and that will be the end. Dr. Edith, thank you.
Thank you, Prof. Let me just run through it. First of all, I have to commend the presenters. They've really done a very nice work. They've brought out some of the implications of this COVID on sexual and adolescent reproductive health. But I have some points that I want them to take note of that can also strengthen their presentation. So I'm actually starting from Kabiru, Caroline Kabiru. Some of the points I'm going to raise also affect other presentations, but I will still maybe mention them briefly. So my first point is, since Kabiru, you are presenting the lead paper, which is all about Africa, I expected that the chart you have, the age charts, should have represented Africa and not just targeting South Africa alone, because you're actually trying to portray what happens in Africa. But most importantly, that chart is 2 months old. And even if you go to WHO website, you are going to see updated data sets on daily basis. So I expected that, you know, at least if it had been maybe August 25th or so, it would be fine. Now, you have a nice framework, which was very commendable, but I think it could have been better if you had used that framework to highlight some facts and figures in Africa, or using various regions of Africa. Instead of just saying, well, for example, if you are talking about teenage pregnancy, maybe you could have given us some facts using that framework. It would have brought out more impact. Now, most importantly, you are using the Ebola crisis as trying to use it as an example. Now, the question is, African governments or people that suffer that Ebola crisis, were they able to, were they proactive during this COVID based on the experiences they had during Ebola crisis? Were they proactive, or were they also just being reactive to what happens? Were there policies that these governments put in place in case some of this pandemic occur again, how to protect the rights of these adolescents? Or if there are policies, we will want to know. And if the policies are there, how effective have these policies been? Now, for example, how were they able to rehabilitate victims of these SRHR? Were they able to rehabilitate them? Because it has overall impact on their health, it has an impact on their mental health, on their physical health, even on their socioeconomic potentials. For example, a teenager that drops out of school because of pregnancy, of course, the future has already been affected. So we want to know, we would have wanted to know, what have the African government done in these aspects? Now, finally, I expected also to have seen a kind of snapshot. What aspects of gender-based violence were encountered? For example, child molestation, rape, child labor. Some of those things were recorded where children were forced into child labor because they're at home, or where they are molested. Some of them were even burnt with electric press iron. Could you have brought up some of those things? And what have been done to sanction the perpetrators of this, the people that violate these rights? Because if nothing is done to them, tendency is that tomorrow such a thing will see repeat itself. And finally, you made recommendations, but the last question I have for you is, what exactly did you conclude? You need to give us, a specific conclusion on your paper. Now, going to Akin in Nigeria, you have a map of Nigeria, which was showing the geopolitical zones and the states. I would have preferred that map should have shown the incidence or prevalence of COVID-19 in Nigeria. It would have made more sense, instead of just showing us those states there. Now, perhaps in that map, show us what is the vulnerability of Nigerians to COVID-19. Are there adolescents that were affected or infected by this COVID in Nigeria? We would like to know that. Are they affected? Because if they are infected also, it will also affect their rights. If they're not affected, if you're not affected, we should know, because this is what can aid policy tomorrow, so that government can plan ahead for this kind of thing, not waiting till another pandemic comes before we start looking at it. Now, just like I mentioned to Caroline, are there any attempts to show that the rights of these adolescents during this COVID are maintained? Look at the topic of the webinar that has gone about the rights itself. So I expected you to come up with something like, okay, for example, this was what happened in Ebola. Ebola was in Nigeria. Now that we have COVID, what is happening? For example, I know that earlier this month, the Minister of Women Affairs in Nigeria said that they have more than 3,600 rape cases in Nigeria. I expected some of this highlight to have come up. Who are those people perpetrating this? What are the categories of people? Where are those things happening? It is all over the place. And the United Nations Women also refer that there is a 300% increase in gender-based violence in Nigeria between March and April 2020. These are things that, these are the actual impact we are seeing that we can compare with what happened during the Ebola crisis. Because it seems you are, okay, you are just saying Ebola, this happened in Ebola, and you need to make a projection of what we expect. But already we are having data of what is happening. So I expected that you should have brought up those things. Lastly, your recommendations they are very nice, they are very apt. But just as I asked before, are there policies that government has brought out to make sure that the rights of these adolescents are secured or not? Because this may not likely be the last pandemic. So if there are policies, we want to know those policies. We want to know how effective they are, so that it can prevent the occurrence of such things in case of another COVID, another pandemic. Now to Vespa, Dr. Vespa, a nice one. You use the maps, you know, your maps were so illustrative, and I commend that, which was showing that the percentage of adolescents that were infected, they have 5% infection rate of adolescents in Zambia. At least that gives a clear picture, meaning that even though they are not more vulnerable to this infection, they can be affected. And of course, it must have implications on their sexual and reproductive health. Now, the maps, as I say, are commendable, and there's a lot of story about the locations and volume of infections. Just like you mentioned, 300 health workers were infected. It would have been nice for you to highlight with statistics aspects of sexual and reproductive health that were affected by the pandemic. If you have it, it will be nice. Just the same way you were able to mention specifically, this is the number of health workers that were affected. And just, you can also look at the question I asked Caroline about government policies. Now, your recommendations are very fine, but you need to mention, how do we ensure that the rights of victims of gender-based violence are assured? And how do we plan for future occurrence? Is there something like that? Because it's not an issue of just saying this thing happened now, this other one happened now, and we end it at that. There must be a policy, there must be a roadmap that will help us to try to tackle those things in future. And lastly, to talent, you also did a very nice work. And more importantly, the trend you presented about the COVID cases are very commendable. You know, the timelines, that was what I was mentioning about Kabiru's presentation. We need to see those timelines. It's very important to know when it is increasing and decreasing, because those are what can inform interventions. It would have been desirable if the impact of SRHR highlighted with data or tied to specific regions of the country. You never tied any of them. You never presented any data at all to say, okay, this is what has happened, or this is what is happening, or this is where it's happening. Just like Vespa had a map to show, okay, this is the particular region where this thing started. Such a thing would be interesting to have that. Then what happens to the victims in Zimbabwe? The victims of this, the reason that their rights are trampled, in terms of what happens to them. Do you have information on that? If you have information on that, we will want to know, because it has potential and potential implications on their well-being based on reported cases. That is, if you have reported some cases. For example, if somebody was molested, it has a potential, it has implication on the person's well-being in future. Your recommendations are very fine, but you never mentioned, you never showed us how we are going to ensure that the rights of victims of gender-based violence are maintained and how we are going to plan for future occurrence. At this juncture, I think I have to stop and thank Professor Megu and IUSSP for giving me this opportunity to discuss these papers. Thank you.
Thank you, Dr. Edozie. Okay, I think the floor is open now. There are a number of questions on the board. I think one major question I see here is the question, about 6 persons have asked that kind of question. Any idea about whether access to abortion has been affected during the pandemic? The presenters, I think starting with Caroline, will try to attend to that question, or any of the presenters. You know, yeah, that's the one question I see here that is dominant. Caroline, sure. Yeah, any evidence or anything to show whether access to abortion services has been affected during the pandemic?
Well, I do know that there have been reports from DKT International about disruptions in supply of products such as medical abortion pills, which could have a direct effect on abortion services, but perhaps some of the other panelists might have specific data, because mine is more from a report that speaks to that.
Okay. Anything from the other presenters? Do you have any evidence?
Yeah. From Zimbabwe, you'd find that mostly the medical terminations are usually done at the centralized hospitals, and there's been quite issues to do with the restriction of movement. So having to move from the large distances to the central hospitals or district hospitals, the adolescents have been facing challenges in accessing the letters that would allow them to access the service. Though the numbers are not much, I think it's a service that probably is an issue that is going unreported anecdotally, but the numbers are very few at the moment. Thanks.
Any other view, or do I go on to? There's a question for Vespa. Vespa is asking, agreed that GBV affects both sexes, and it has COVID has in fact led to increase in violence against men. Any evidence from your own study, from your own review?
Okay, I do agree that it does impact both sexes, but we know that the women are the most victims in this case. In terms of evidence, the data which would be available would be from organizations that deal with gender-based violence. I haven't been able to access it, but if it's needed, that can be accessed from organizations that deal with gender-based violence. The statistics that are available mostly on the victim support website, which is a wing of the police unit here in Zambia, they do document this, but the latest data that they have there is of 2018. As you can see, we hadn't yet had COVID then. But most of the data or the evidence that would be available to show this would have to be gotten from other organizations.
Okay. So there's a question from Tom, ISSP President, whether all the studies that have been reported here from English-speaking African countries, Then he's saying that, yeah, will the situation and the public response differ in French-speaking Sub-Saharan Africa and in North Africa due to differences in institutions, laws, and cultures? Yeah. Do we think that what we presented from English-speaking Sub-Saharan Africa will be different from what we can see from French-speaking Sub-Saharan African countries and North Africa?
Well,
yeah.
Let me come here. That was actually the major issue I was raising from Caroline's presentation. We could have had a snapshot of what is happening in different parts of Africa, even though we can use these ones as a basis. But of course, just like I mentioned, if you go to WHO website, the data is there. A comparative pictorial presentation would have solved the little problem and helped us to also interrogate if the experiences are the same or not. Thank you.
Any question from, that's a question from, I think, Nigeria. He says that presenters focus mostly on the effects of COVID-19 on female adolescents. What about the impact of male adolescents, especially referring to Akiode and Shisumba's presentation? What do you have to say after that?
Yeah, when I was discussing, I think I raised that issue. Issue of child molestation is not gender specific. You know, the little children that are being molested in the households, that could have been brought out also, not just saying, okay, this happened during COVID. The news are all over the place. You can actually get one or two instances of such things. So it can happen to either a male or it can happen to either a female, but we need to extract the statistics or the instances first.
Okay. What do you, Akiode and Vespa, do you have anything to comment on that? Do you have anything about impact on male adolescents from your own country perspectives?
For me, nothing specific, but I think this also highlights the some of the points that Caroline mentioned in our presentation, which of course is the somewhat injustice of researching mostly female adolescents. So most of the evidences are available, empirical evidences are available, but of course there are reports here and there on a couple of reports here and there about how this may have affected males. But that's, we need to begin to study these two hand in hand rather than focus mostly on the female adolescents.
Just in addition, I think, yes, I do agree. I think for now, since we are still learning about the epidemic, more information is being collected. And as information is being collected, at some point, certainly we'll be able to differentiate the period before the epidemic and the period after the epidemic. So for now, the data that are available are programmatic data, and these are still being compiled. But I'm sure in time, we should be able to have all the data that should enable us to be able to compare the differences in the periods.
Yeah, I think also I want to comment that actually this webinar, the objective is really to try to frame right questions that will be asked in subsequent field surveys. As at today, there has not been any study that took time out to ask questions, relevant questions that can bring out clearly indicators, because everything that you are reading from the journals, from even presentations, happen to be just conjectures, you know. It's something like expected impact or potential impact. But there's no way we can now link up increase in teenage pregnancy to the public. So the idea for this webinar is really to help generate reasonable kind of questions that will be asked in forthcoming studies, because what we're doing now will lead to a study that we are proposing later this year or early next year. Having said that, there are two main questions that I would like to hear. Caroline, that first question actually came to you. It was asking whether is there any policy for the management of pregnant learners in schools in Sierra Leone? Caroline.
Can you
Hello?
hear me?
Yes,
Hello?
yes, yeah.
Okay. Yes, I'd responded to that. Sierra Leone did in fact have a policy that banned pregnant adolescents from pregnant girls from attending school, but that ban was actually lifted this year. So in fact, the answer is that right now, pregnant adolescents can attend school in Sierra Leone. But I did want to respond to one of the questions or some of the pointers that were raised about the impacts, and just sort of echoing what you said, that actually there is very limited data on the effects of COVID on adolescent sexual and reproductive health. And that is why I chose to focus, for example, on Ebola, which was an epidemic, and there were a couple of studies that were able to look at the impacts of the epidemic and some of the resultant measures. In fact, it's actually hard to come by. We assume that there is data on even age distribution. So I was forced to go to a data set that was showing the breakdown by age for South Africa in June, because for many of the other countries, it's very hard to get a breakdown by age so that you can pull out the adolescent component, or to show exactly how adolescents fare. So like you said, there is a dearth of data, and I think that's one of the points I was also trying to make in my presentation.
And that is really one of the key objectives of this webinar, to generate kind of questions and on research questions on the kind of methodology that will be used to answer critical questions about the impact of the pandemic on sexual and reproductive health indicators. A question here for the panelists is from Mugo Waweru. He says that read newspaper reports that mothers were skipping antenatal care and postnatal care services, and they're doing home delivery because of fear of the risk of contracting COVID-19. To the panelists, do you know of studies in this area? Any idea?
I don't know of any that are related to COVID-19, but in the paper that had shown on the Guinea paper by Kamara et al., they actually did look at the effects of the Ebola epidemic on institutional deliveries, and they found a significant drop during the peak. And unlike the use of family planning, the graph that I showed, where the numbers sort of came back to near pre-epidemic levels, in this case, the numbers did not for institutional delivery. And they were suggesting that that may reflect women during the epidemic, moving on to perhaps the use of traditional birth attendants, and even post-epidemic that remains. So perhaps for institutional deliveries, that recovery might be slower than, say, other services, uptake of other services. But like I said, I don't know any paper that has looked at the impacts on institutional delivery.
So, any more questions from the participants. All right. Any question? Okay. I think Mary and Paul, I'm not getting any other question. Okay. So this continues, this webinar continues tomorrow. Tomorrow we are going to look at issues of rights, unintended pregnancy and schooling, gender-based violence, and issues of disability. Look forward to seeing you. It's not over yet. And your questions will help us to formulate our ideas in what we want to do. I want to thank all the panelists, the first speaker, the technical team, Mary and Paul. You've been so wonderful. And the discussants, thank you very much. Please bear in mind that this is just to help us formulate research questions. We know everything here should be potential. We hope another conference is coming up sometime next year. We hope we are going to have data to really speak to some of these things. And Mary, do you have any comments?
No, I want to thank everybody and all the speakers for being here and being patient. We had a little technical difficulty. And for our next webinars, we hope we can